a little bit shorter than the other speakers. So I'd like to start by just saying it's truly a pleasure to be here, and I want to thank everyone from the Planning Committee and all of those involved in this work. It is an honor to be speaking at this event, and really happy to have an opportunity to share with you a bit about City Health Works, an organization near and dear to my heart, and to share with you a story about a patient and her work with one of our amazing health coaches. So let me see. I have some slides. There we go. So I'm going to open my remarks by saying that there is increasing recognition, as we all know, among health systems that people with more complex medical and social needs cost the health system more money. And there are many remedies that have been offered, from technology to policy changes, payment model changes. But as a healthcare practitioner, as a certified diabetes educator, I would argue that we don't speak enough about operational design, about building programs that work and that can effectively identify and address the needs of our patients. This is truly the key to delivery of health services that have financial stability and scalability. At City Health Works, we're trying to bridge that gap one neighborhood at a time by focusing on operational design. And so we know that 50% of healthcare spending is on 5% of the population. A key driver of this challenge is that our health system is missing a layer of support for people's ability to manage their own health care. The majority of the activities that are required to manage the day-to-day reality of living with a chronic illness take place in the home, from what people eat, to their activity level, to whether or not they monitor their health. But for most clinicians, the home is a black box. They have no idea what happens there, and they don't know how what happens in the home affects health outcomes. In addition, patients lack the tools that they need to manage those conditions at home and to prevent avoidable crises that bring them into the emergency room and that result in lengthy and costly inpatient stays. So our work at City Health Works is to try to address that problem, and we primarily work with elderly patients who struggle with multiple chronic illnesses. These people are dealing with stressors such as depression, anxiety, poverty, and we partner with the clinics and hospitals that serve them to support their ability to deliver care coaching and care coordination across multiple medical and social service sectors. So this is one of our wonderful health coaches, Maricillis, working with a patient outside, helping her to be more physically active. So as you can see, our vision is to create stronger, healthier neighborhoods. We believe that people have a deep capacity to take greater control of their own lives and their own health by gaining the knowledge, skills, and confidence to do so. Our mission is to act as a bridge, as a trusted partner to clinicians and to patients, and to extend the reach of clinics and strengthen the abilities of patients to monitor and care for chronic illnesses. We believe that health systems and social services can be more effective with stronger, more supportive connections to the people that they serve. So what makes City Health Works unique? I think one of the things that makes us unique, and I hope all of our health coaches are watching, is their unique ability to build trust with patients and clinicians. Our founder, Mamie Kaur, when she started this organization, was struck by the 10-year mortality difference between people living in East Harlem and those living on the Upper East Side. These are adjacent neighborhoods. And she decided to start her work in East Harlem in close partnership with Mount Sinai IMA Clinic and Settlement Health. We hire health coaches who live in the neighborhoods that they serve, who have shared life experience with their clients, and who become integrated in the care teams of our partnering clinics and hospitals. What makes us successful is a 4-ingredient model. the way that we deliver services. We aim to fill the missing layer between medical services and the home. Through empowerment, empowering our clients with the knowledge, skills, and confidence to be able to successfully manage their own health. Through collaboration by co-designing our model with our clinic partners and with our coaches. Through custom technology, and through methodology that helps to develop the workforce and to integrate into the clinic. So I'm going to share with you a story of Hilda. Here's on the screen. Hilda is one of our rock star health coaches. And I want to share this example of a high-need patient who's been working with Hilda since October 2016. We have received permission from this patient to discuss her story, and I'm going to call her today Ms. Smith. So Ms. Smith is a 56-year-old woman, African American, who had a stroke 6 years ago that left her with aphasia and a partial paralysis on the right side of her body. Ms. Smith recently returned home to live with her mother after suffering through a domestic violence event because she didn't have anywhere else to go. Now, even with her challenges, I'm here to tell you that Ms. Smith is motivated, she's positive, she's energetic, and she is engaged in her care. She attends wheelchair classes, Zumba, and cooking classes for stroke survivors. And she regularly sees a social worker about her past trauma. Despite all of this, at the time of her referral to City Health Works, Ms. Smith could not seem to get her A1C out of the 9 to 10 range, which meant that her diabetes was not controlled. One of the reasons that her diabetes was not controlled is that she was suffering under tremendous emotional stress and not eating well. But no one knew this, and this information had to be uncovered. So one of our themes is the trust grounded in a listening patient relationship with a health coach that was developed between Ms. Smith and Hilda. In her first session with Ms. Smith, Hilda said that Ms. Smith opened by saying, "My mother is a beautiful person, but," and then she started to cry. And she told Hilda about a behavioral health condition that has made it very difficult for her to live with her mother. She doesn't allow her to buy or bring in any healthy foods into her home, and she doesn't allow Ms. Smith to have any visitors in her home. So Hilda, when she's doing sessions with her, has to meet with her in the hospital lobby. In order to address some of these issues, Hilda referred her to a local food pantry that allowed her to get hot meals and also to get a takeaway bagged healthy lunch when she needs them. Hilda also helped Ms. Smith to get on a waiting list to get support and housing specifically for survivors of domestic violence. And Hilda's working with her mom to help her get the help that she needs as well. Another theme that arose during Hilda's work with Ms. Smith is that she had trouble getting the right prescription from her pharmacy. They told her that her prescription had already been filled, which was not the case. So after numerous calls between Hilda and Hilda's supervisor and the client and the physician and the pharmacist, after all of this troubleshooting, they found that there was a duplicate profile in the system of the pharmacy. And after that problem was resolved, Ms. Smith was able to get her correct prescription. So our takeaway from this is that there's a dysfunction inherent in our fragmented care system, where we have data that's collected at multiple points along the healthcare journey, but patients and providers are not able to communicate about that data. The burden is placed on patients and their caretakers to navigate, and this is particularly hard for people who are dealing with functional or other sorts of limitations. A third theme that arose in Hilda's work with Ms. Smith is a lack of support and a lack of knowledge that she was provided as she was working through her issues with diabetes. Ms. Smith revealed to Hilda that she hadn't been able to check her blood sugars She had been prescribed a blood sugar monitor, but she didn't know how to use it. She also was not able to use a lancet because her right hand was weak from the stroke. No one had ever identified this before or worked to address these issues with Ms. Smith. But Hilda was able to instruct her in how to use the machine and was able to get a very easy to use lancet that was designed for people with physical limitations. So without instruction, even for you and me, sometimes using medical devices would be tricky. But for a high-need patient like Ms. Smith, it's almost impossible for her to figure out on her own how to overcome the barriers inherent in using these sorts of medical devices. She needed the extra time and support from her supportive health coach, Hilda, in order to figure out how to use the blood sugar monitor and whether or not she would be able to use it in the way that was typically described. A major factor behind why many of Ms. Smith's needs were unmet, despite her level of motivation and engagement and regularly seeing a social worker, was due to her slow and slurred speech because of the stroke. As we all know, provider visits are very brief, and so taking the extra time to listen to someone who speaks at an abnormally slow rate would be very difficult. And providers often did not have the time to listen patiently to all of Ms. Smith's needs to make sure that they were addressed. Further, due to the sensitive nature of her difficult relationship with her mother, Hilda played a powerful role in addressing these issues early on. By taking the time to listen patiently and building trust, she was able to get the patient's food and medication issues addressed, build her support network, and refer her for safe housing. Hilda also did her regular health coaching work. She provided Ms. Smith with the knowledge and skills and confidence that she needed to do well. Ms. Smith reports now that she eats very healthy. She reads food labels. She tries to watch her portions. As of a week ago, Ms. Smith's A1C was 6.2 after being in the program for only a few months. But we know that she would not have been able to control her diabetes unless her other issues were also addressed. This case study just highlights how a combination of complex medical and social profile issues combined with the fragmentation in our care system resulted in a significant need for a health coach for a patient like Ms. Smith to help her take control of her health and address her barriers. So I just want to talk a little bit about our operational design, because we think this is really important in making sure that patients who are high need are getting the care that they deserve. We work to empower clients with the knowledge and capabilities and confidence to self-manage. So we work with them to set realistic health goals. We personalize and adapt the curriculum according to their learning, cultural, and social needs. We engage the patient, their caregivers, and their family members in skill-building work around reading food labels or designing a healthy plate. And we've seen that patients' confidence increases. They are able to teach these lessons to their neighbors and to their friends. And through this model, we're able to spread this into the neighborhood so that other people can benefit. We also reward our clients with these beautiful certificates of completion. And for some of these clients, this is the first time they've ever received a certificate of completion for anything. And so they are very proud of them, they value them, they put them up on their refrigerators, and it reminds them of the work that they've done and the skills that they've achieved in the program. As I mentioned earlier, we work very closely with our clinics to co-design our workflows and our model. We also use and utilize the feedback from our health coaches who are out in the field and know the most about what is ailing those in their neighborhood. We also have built a custom technology that helps us to streamline the way data is collected. We have surveys with drop-down menus and bilingual functionality and data analytics that make it easier for the coaches to do their work. Part of our methodology is a 4-part screening process to hire our coaches, our rock star coaches. I hope they're all watching today. They are hired from the neighborhood. They have a minimum of a GED. It's a full-time job with benefits. They have intensive upfront training. And I know it's intensive because I'm responsible for that training that they receive. They have clinical supervision from a certified diabetes educator, a dietitian, or a nurse. And they also work with a social worker. And they have a very transparent and regular process of performance reviews so that they can continue their learning process as well. For the coaches, it's not just a job, it's a passion. But they're also able to get a full-time salary, good benefits, and a career path that might not have been available to them otherwise. As we work with our partners at clinics, we want to align our coaching goals with the clinical team because we're not a standalone service. There's bi-directional regular communication between the care team. Clinicians and social workers are able to follow their patient progress towards their goals, and they're able to respond to the urgent medical needs that may come up during the time that the coach is working with the patient. So we have found that with the unique insight of a coach working with a high-need patient, they are the eyes and ears for a physician, for a clinician into the home. And for 1 in every 2 of our patients, we have been able to identify a critical medical issue that was otherwise unknown. And we believe that half of those might have resulted in an emergency room visit. So just quickly, some results to date. We've served over 600 patients in the Harlem area. Most of our patients are elderly, as I mentioned before. 95% of them have multiple chronic conditions, multiple medication challenges. 50% are dual eligible. 40% report that they do not have good communication with their provider, which is something that the coaches work with them on. And so these are your high-need patients. We work with clinic and community partners throughout Upper Manhattan and over 30 community sites in Harlem. And we're having good results. Our clinical outcomes are good, as I mentioned with Ms. Smith, but over 83% of our patients have a reduction in their A1C. Our patient satisfaction scores are high. Patients really enjoy this opportunity to work with a health coach, someone who is focused on their health needs alone. Providers are happy that they're getting better informed care, that they know about what's happening with their patients, that they have a window into this black box that is the home. And there's a cost savings. In an initial assessment of our first 74 patients, we were able to achieve a $600 per member per month drop in spending at week 10 in the program, and a $900 per member per month drop in month 5. We are working currently, we finished a demonstration project with Mount Sinai. We're working through a PCORI asthma study. We're working with Metropolitan Hospital on a diabetes and hypertension health coaching program. And we're about to start a transitions of care program at Mount Sinai St. Luke's for congestive heart failure. And so just some final thoughts. Our next steps are to establish our first payer contract with an MCO in New York City. We're preparing for operational capacity to scale across New York City and outside of New York City. And we want to shift the norm in the marketplace so that delivery systems develop strategies that extend the 4 walls of the healthcare system to equip patients with the tools and support that they need for successful self-management. We're currently working with the Urban Institute, doing qualitative and quantitative research. This is a year-long partnership enabled by a fellowship received by our CEO, Mimi Kaur, that partners practitioners like myself and our entire team with policymakers and researchers to unearth insights from our coaches, from our patients, and from our providers to inform sector-wide understanding of how to solve these problems and how to make sure that our high-need patients receive the best care. Thank you.
Thank you very much, Jamillah, for that touching and hopeful presentation. You set the stage so beautifully with your account. We have time for a couple of questions if anyone would like to raise them before we move to here. Yes.
How are you
would you please stand up to the microphone? I should mention, as you heard Jamillah referring to the fact that people are watching. I think we have a couple of hundred people, maybe it's more than that, who've signed up to watch on webcast, so please use the microphone.
I'm Dr. Caroline Poplin. I'm a primary care physician. I work at the Arlington Free Clinic in Virginia. I have two questions. Number one, how are you funded? And number two, the social workers, are they from the city, or do they work for you, or do you get them from some other place?
Okay. So we've raised about $5 million of philanthropic funding since 2013. So we've partnered with Robert Wood Johnson, Robin Hood, other funders have been very generous in their support of our testing of the care model, refinement of the care model. We're now getting a lot of paying customers and seeking to refine the way we are structuring our financing. And that is something that Mamit, our director, is working on, securing venture funding and other sorts of funding to allow us to grow and to scale into other neighborhoods. Regarding your question for social workers, the social worker is employed by City Health Works. So we are working directly with someone who is our employee and is providing services both for coaches and also for clients who may need those services.
If I could say,
Yeah.
in response to the answer to the first question, what concerns me is once you start to pair with for-profit MCOs, there may be an incentive to look for the easiest to work with patients. They're the ones who achieve the greatest difference and cost the least.
Yeah, we are hoping to keep the fidelity of our program going, and any funding that we receive, we will want to make sure that we're aligned with our core mission and our core values moving forward.
Thank you. I think we'll hear more about that particular element throughout the course of the day as well. One more question?
Hi, yes, my name is Marilyn Navarro, and I just have one question. What is the caseload for the coaches per your population?
Yes.
And I can take that sitting down.
Thank you. So the coach's caseload is around 25 to 35 clients, and that works really nicely because they have the time to meet individually with patients. Our model is such that it's very intense up front, and then as time goes on and patients have become stronger in their self-management skills and they're able to do most of this work independently, the coach is able to transition to a mostly phone-based relationship. And so they have a mixture of patients that they're meeting very intensely and patients that they're primarily having a phone-based relationship with. So they are able to kind of keep that caseload in that 30-some-odd range because of that.
Thank you again very much.
Thank you.